भजन चल रहा है इसलिए स्कार्प है।
ओके, यहाँ पे बारिश चल रहा है।
अब
यहाँ
बारिश
पर
यहाँ भी है,
बारिश है।
पर अभी
महाराष्ट्र
थोड़ा
में बहुत
हमारा
हो रहा है।
जहाँ हूं मैं वहाँ थोड़ा अभी ये चल रहा है।
बारिश में कभी
ये-
कभी इंटरनेट भी अनस्टेबल हो जाता है
हाँ
सर।
वो तो है ही, वो तो है, इसलिए।
Dr. Monica has joined.
मोनिका हैज
Shall we
I'm there,
start?
I'm there.
Dr.
I'm
Monica,
there,
चालू
sir.
करायचं?
Yes, sir. Monica has joined, sir.
Yes.
Shall we start?
Yes, we
Okay,
can
sir.
go
Yes,
live now.
yes,
Yes,
I
ma'am.
think we can. Yes.
Okay. Good evening, respected faculties and delegates present over here. On the behalf of Corona Remedies, I, Shivani Bhabra, welcome you all for the Core Connect live webinar in association with ECO, that is Enhancing Care for Healthy Outcomes. So first, I announce that our YouTube webinar is live. We are live on YouTube, and I'm sharing the presentation. So first, I would like to introduce Dr. Monica. Dr. Monica is a
Shivani, yes, let's not waste time. Let's start. Everybody has come. So,
No, let her talk for 1 minute. Yeah, Monica.
yes, sir.
okay. So I would like to introduce Dr. Monica. Dr. Monica is a obstetric and gynae, and she is a national coordinator of PSC committee and a zonal coordinator, zone of AMOX 2024 and 2026. So please clap for her and introduce Dr. Monica.
Dr. Monica has won the elections of chairperson of Public Awareness Committee, and she will be taking over from January 26 till January 29. So congratulations, Dr. Monica.
Thank you so much, sir, with all your blessings and seniors' blessing. Gokuldas sir has always given me a thumbs up for whatever messages, and Arun sir also, sir. And I would also like to invite our coordinator for today, Dr. Shatabdi De, and we would not take much time to introduce our convener for today, Dr. Kalyan Baramde sir, under whose leadership we have started this ECHO series. This is the second episode in the series with the East Zone Assam Societies. I would like to introduce Dr. Kalyan as the president of IAGE, my mentor in FOXY, an executive member of MSR, vice president of the IME Maharashtra State, and the past chairperson of the Public Awareness Committee. Sir, I request you to formally welcome all the August gathering today and introduce our chief guest, Dr. Sujata Kar, after the inauguration slide, sir. Shivani, can we have the inauguration, please? We seek blessings from Lord Almighty. The next slide, Shivani. Yeah. Please click on the icon. The voice is not heard. Audio is not heard.
Vani, the inauguration slide.
Audio नहीं आ रहा बेटा. It's okay. Let's proceed, sir, because I think there's an problem with the audio from Shivani's end. I request you to please welcome the August gathering today, sir.
Welcome, everybody. I welcome you all.
Shivani, stop sharing so that sir can be seen properly.
I welcome everybody for ECO webinar series, that is Enhancing Care for Healthy Outcomes. These are the focus webinars for obstetricians and gynecologists. And today is the second episode of this webinar, where we have chief guest Dr. Sujata Kar, who is the executive council member of ISAR and IAG. She's been a mentor for many all over India as well as in the East Zone. And we have guest of honor Dr. Gokul Chandra Das sir and Dr. Arun Madhav Barua sir, who are my mentors in my journey in FOXY and IAG. So today we are going to have a focus webinar on hysteroscopy. As everybody knows, hysteroscope is a stethoscope of gynecologists. Today, with the advance of miniature hysteroscopes. We are able to do hysteroscopy in office setting without any anesthesia also. Hysteroscope has lot of advantages, but the most important advantage is for fertility enhancing surgeries. Whatever lesion which is there in the uterine cavity can be tackled very well with hysteroscope. Today's webinar, we have Dr. Anita Singh ma'am, who was my vice president in 2020 in my journey of Foxy, and who has been a guiding force for us in all our Foxy careers. She's going to throw a light on fertility enhancing hysteroscope. In that, she's going to cover all diseases which can be tackled very well with hysteroscope, that is polyp, fibroid, septum, and even endometrial scratching, whether it is required or not. So she's an ex-professor of Patna Medical College and Vice President Foxy 2020, President of AOGS BG. Now I hand over to Dr. Monica for further proceeding, and I thank everybody for joining this webinar, that is ECO webinar. I thank Corona team for their academic partnership. Thank you.
Shatabdi, can you introduce Dr. Sujata Kar, madam, please? The next slide, please.
I think
Previous
just
Yes,
a few
Monica.
words will be good, Monica. Kalyan has already.
Previous slides, please.
Previous slides, please. You've come for Shivani. I need Dr. Sujata, madam, slide.
First slide. Go
Previously-
back. Go back. Yes.
Yeah.
Yeah.
So can you please request you to please introduce our chief guest today, sir?
Dr. Sujata Kar, madam, she's a practicing gynecological endoscopist and ART consultant since last 30 years. She has won so many gold medals in her MBBS and MD, and she has credited first IVF baby of Eastern Orissa, first TESA frozen embryo and laser hatching babies of Orissa, few awards, Parichaya Award for Women Achiever Odisha, Devi Award for Dynamism and Innovation from Chief Minister of Orissa 2020, Rotary International Women Achiever Award of 2025, and Brand Icons Excellent Award 2018 for Best IVF Center in Eastern India. She has 25 original publications related to PCOS and male infertility in PubMed. And right now she is Vice President of ISAR India, EC member of PCOS Society, Fertility Preservation Society of India, and past chairperson of Odisha chapter of ISAR. I thank her from bottom of heart for joining for this webinar, and she was really helpful to us when we had started our IAG journey. Thank you, Sujata ma'am. Few words of wisdom.
Yes. Firstly, thank you very much, Kalyan, for your elaborate introduction. And good evening to all of you. Especially a very happy Dashera. It's a festive season, and you've had you are still going on with academics. And first, I think, Kalyan, the most important thing for me is that you have remembered me for my first love, which is endoscopy. And I was very, very active with IAGE. And now that I'm a little bit out, you still remembered me. Thank you so much for that. Your journey in IAGE, I must take a minute. We all started together as EC members, but your journey in IAGE has been exemplary, and you've done so well. And now as the president, you're doing so much work, so much activities, so much live workshops, these webinars. Congratulations to you and your team. And also, I would like to thank Dr. Monica and, of course, the Corona team. So for, thinking of me and calling me as a guest in your webinar. And like you've said, hysteroscopy is the most important day-to-day activity that all of us have to perform. And so thinking of this topic as a webinar also is excellent. Thank you once again. I'm sure it will be a great webinar.
Thank you, ma'am, for your words of wisdom for all of us. And we still remember your IAG contribution. And you are the person from East India who needs a big Congratulations for your IIG as well as ISAR journey. Thank you so much, ma'am.
Thank you.
Next slide, please. I'd like to introduce the Professor, Head of OBGYN, Guwahati Medical College, Guwahati, and Founder Professor and HOD at TRIHMS College in Arunachal Pradesh, OSD of Srimanta Sanskar Deva University of Health Sciences, Assam, Vice President of FOXI 2014, President of Northeast Association of OBGYN Societies since 2015, Organizing Chairperson of ICOG Guwahati 2010, delivered guest lectures, oration, panelist, national and international conferences. Welcome, Dr. Gokuldas, sir. And I'd like to congratulate you for getting FOXI conference in 2028. And we were there to witness. You had a massive victory in the voting at MCM in Mumbai. Welcome, Gokuldas, sir, and few words of wisdom for us, sir.
Thank you, Kalyan. It's a pleasure to be with young people. And I'm very happy to see one thing, that endoscopy now has moved to not only A, now it has gone on to B towns. Now very soon it will go to the rural areas. Because already the people who are joining here in the panel some of them are from the B towns of Assam. So it's a very healthy sign. And your efforts and the efforts of your, earlier presidents in promoting endoscopy to the grassroots level is bearing fruit. I'm sure this is going to help our patients a lot of things. So welcome you and welcome your efforts for promoting endoscopy at the rural level so that the people can really benefit from it. Thank you. Thanks a lot.
Thank you. This year we have taken hysteroscopy as our main target, and we are conducting 30 workshops across Tier 2 and Tier 3 cities. We had already 2 conferences based on only target hysteroscopy for 2 days, all 20 cases on hysteroscopy itself. So IIG is making all the gynecologists learn hysteroscopy because hysteroscope is stethoscope of gynecologists. Thank you, sir, for all your contribution in making East India so prominent. And we could see the vibe in arranging 2028 AICOG at Guwahati, sir. Congratulations for that.
Thank you. Thank you. Thanks a lot.
Arun, sir, slide, please. So he's our mentor again in IIG, and his work is a really guiding force and going to be inspiring for all youngsters. He's from such a small place, but he has made his mark all over India. Anybody we ask from Guwahati or Assam, he says, I am Dr. Arun Barua's friend. That's what he's made endoscopy and IVF famous in Assam itself. Consultant at Apollo Fertility Guwahati, Assam. Chairperson of Northeast IIG, founder chairperson of Northeast of ISAR, past president of Dibrugarh OBGYN Society, senior vice president of IMA, Assam State Branch, and vice president of SOVSI, active Rotarian since last 25 years. Sir, can you just guide us for this webinar series?
Thank you so much, Kalyan, for considering me to be included in this very seminar, which I think really very important for this part of the country, because the endoscopy in this part has not been able to catch up earlier. But as Gokuldas sir has rightly said, we are trying to catch up first, and the webinars like this will help us to reach out further inside the areas where these are possible. As you rightly said, hysteroscopy is a part and parcel of the gynecological examination, and we feel of a hysteroscopy in real sense, that means without anesthesia and without any other strong analgesics, it is a possibility. And you can make a diagnosis, and with the diagnosis itself, you can even treat. So see and treat, that is very prominent in the Western countries, is a possibility in the Eastern region of the country also. We know amongst ISG and all other metros in the country are taking up hysteroscopic surgery in a very regular basis. And I'm sure with time, we are going to catch you very fast. And this seminar, I'm sure, would add a lot to it. And at least your vision of considering this for this part will be really fruitful. Thank you so much. Let's get back to the scientific agenda as soon as possible.
Yes, sir. Thank you for the blessing. The next generation people, Dr. Hafizur, Dr. Prerna, Dr. Lugan, Dr. Pratibha, and also Dr. Pranay, Dr. Alka, they are going to take hysteroscopy ahead, and that is going to be really great that it will be a popularized hysteroscopy in East India. And there are few people who are popularizing laparoscopy in your region. Now it's turn of hysteroscopy. So I like to start the session. I like to invite Dr. Shatabdi for introducing the chairpersons. Dr. Shatabdi, chairperson's introduction, please.
Shivani, can we have the next slide for the chairpersons? This is the speaker slide, please. Here, our chairpersons for today, Dr. Pranay Phukan, sir. The previous slide. Previous slide, Shivani, please. Yeah. Dr. Pranay Phukan, sir, is a professor and the head of the department at the Tinsukia Medical College, Assam. He has been a teacher of the undergraduate and postgraduate for the last 34 years and a university examiner. Also the ICOG visiting professor. He has received the AO for Young Gynecologist Award in 2022, and he's been the president of Dibrugarh OBGYN Society since 2022. Sir, it is an honor to have you on stage with us today as a chairperson for the talk by Dr. Anita Madam. Our next chairperson is Dr. Alaka, ma'am. The next slide, please, Shivani. Dr. Alaka Banerjee is an associate professor at Silchar Medical College and Hospital. She has been recognized as an undergraduate and a postgraduate teacher and examiner. She has been a faculty at various conferences. We welcome both of you, and I request you to please introduce our speaker for today, Dr. Anita Singh, ma'am. Alka, ma'am, or Pranay, sir?
Yeah. Thank you very
Yes,
much
sir.
for
I'm
kind. We are really fortunate to have all of you, those doyens of endoscopy amongst us. I'm just going to introduce Dr. Anita Singh. She's the ex-professor of Patna Medical College. She's the vice president of FOXY 2020, and she's the president of AOGSBG, chairperson of IIG Bihar chapter, chairperson of Endocrinology Committee, FOXY 2014 to 2016. She's a member of She's a member of Governing Council ICOG 2015-2022, and she's a past president of POGS, Patna Study. So it's very nice to have Dr. Anita amongst us. I just request her to start her talk.
Thank you, Dr. Phukan, for such elaborate introduction. Will somebody remove the slide from the...
Yes, fine.
Okay. So, wish you all a very good evening. At the outset, I want to thank Dr. Kalyan, along with his team, as well as Corona Remedies for organizing such a good program. And Sujata Kar's presence herself indicates how successful this webinar is going to be. I am a great fan of Sujata since many years, many decades, I can say. Regarding the topic that is hysteroscopy, I always say to my students that one can do without laparoscopy. The things we do with laparoscopy can be done by laparotomy, but the surgeries that we do by hysteroscopy, those cannot be done by any other method. So I think we should make our students learn hysteroscopy first and then laparoscopy. But most of the time, laparoscopy seems easy and people become expert at laparoscopy and forget about hysteroscopy. So Dr. Kalyan, it is very good that in your second program itself, you have taken up hysteroscopy in a great way. So with that, I come to my lecture. I'll be talking about the important topics only, which are many a times done and which are proven things that this surgery will certainly be improving the reproductive outcome of the patient. I will simply touch upon those topics, which are still controversial and not being practiced very widely. So, can I share my slides? Can I share my slides now?
Yes,
Hello?
ma'am. Yes, ma'am.
So the topic given to me is role of hysteroscopy in fertility enhancement. We all know that infertility is very common, and it is not only the female factor, but the male factor is also there. And a large chunk falls in unexplained infertility group. And with the advent of hysteroscopy as one of the diagnostic tools for infertility, many of these conditions which were previously thought to be unexplained are now being explained. Amongst female factor infertility, PCOS is a
I
very
request everybody else to please unmute themselves.
please mute themselves.
I
PCOS,
meant that, but
PCOS is the largest contributor for infertility. Then comes tubal factor, and then there are other factors. And uterine factors fall in those other factors of contributing to infertility. Uterine factors in infertility are mostly congenital, and it can be acquired also. In congenital factors, there can be aplasia of the uterus. We'll not be talking about that. There can be septate uterus, biconvate uterus, uniconvate, or T-shaped uterus. In acquired conditions, the most common one are polyps, uterine polyps, fibroids, some mucosal fibroids especially we'll be talking about today, Asherman syndrome, and sometimes foreign body, mainly the bony chips left behind following previous medical termination or surgical termination of pregnancy. Nowadays, even one condition that has become quite commonly we come across, that is isthmosyle and chronic endometritis. Diagnosis of uterine factor infertility.
Dr.
There are some
Suchitra Sahu, can you
doubts.
mute yourself? Dr. Suchitra Sahu, please mute yourself.
Diagnosis of uterine factor infertility can be done very well by transvaginal sonography, sonosalpingography. One can take help of 3D transvaginal sonography, especially in cases of Mullerian duct abnormalities. Or if there is still some confusion, we can subject the patient for MRI study. But finally, the gold standard for confirmation of diagnosis is hysteroscopy, and it is useful because if we have already done the diagnosis, we can proceed and plan the treatment at the same sitting. There has been comparison done between 3D ultrasound and hysteroscopy in detecting intracavitary lesions, and we can see that hysteroscopy has got very high sensitivity and specificity as far as the diagnosis of intracavitary lesions are concerned. And it has got a diagnostic accuracy of about 99.5%. So what is hysteroscopy? It is a procedure which provides crystal clear, magnified view of the uterine interior, and that also allows surgeons to identify and address fertility impacting conditions in a very precise way and with minimal discomfort to the patient, as had already been mentioned by the previous people who talked about hysteroscopy, that it can be done in the office as a simple procedure. Why hysteroscopy is so much important in cases of fertility management? Because it has got diagnostic excellence, and the procedures which are devised to improve the fertility have shown quite improved success rate. Diagnostic and operative hysteroscopy can be done at the same time, but if the diagnosis is still in confusion, and you are not prepared for that, then you can postpone or you can counsel the patient and make her know what you are planning to do and do operative hysteroscopy in the second sitting. But with the advent of 3D ultrasound and other diagnostic in our armamentarium, in most of the cases, we are sure from before what is going to be the diagnosis, and you can proceed at the same sitting for the surgery. It has shown a very good impact on fertility outcomes. In diagnostic accuracy, we have already talked about. Depending upon the condition for which the surgery has been done, it can show very good results. And even in IVF also, it shows a better result. Now, first of all, the most common one that we come across in uterine abnormality is that uterine septa. Uterine septa is one condition in which there is worst reproductive outcome and very high incidence of early miscarriage. So, hysteroscopy, it has been seen that hysteroscopic septal resection has shown very good results. So, it must be done before starting treatment of infertility, before treating infertility if she is diagnosed, the patient is diagnosed with a septate uterus, because it is very simple and safe. So we should not wait for the miscarriage to occur before offering her septal resection. Septate uterus is diagnosed very well by transvaginal sonography, by looking at the two ostia and seeing the length of the projection inside the cavity, and as well as the differential diagnosis from bicurnovate is done by looking at the upper surface of the uterus. If it is convex, then you are dealing with a septate uterus. While doing a resection of uterine septum, the dictum should be that you should always remain in the midline, and your dissection should go from one corner to the other. In this, you are seeing that it is being done with a hole. Previously, we used to do with the knife, with the help of knife, applying monopolar energy. But nowadays, most of the time, this uterine septal section we are doing with cold seizures, in which there are less chances of risk of perforation, and the operation is quite successful even with cold seizures. But you should always keep in middle. Oh, there's something wrong. I could not change it. But you should be very careful. After each cutting, you should look at the two ostia and see and you should always look at the two ostia that, oh my God. That you are not deflecting from the line of your incision. And when you go to the nearer to the ostia, you should be very careful, because that is the weakest area where you can land in perforation. And at the end of the operation, you should see from the middle of the cavity, the two ostia should be very well visualized, and usually a roomy cavity has been formed to have a good outcome in the next pregnancy. There is a lot of controversy regarding prevention of adhesion, whether we should put up post-operative barrier, IUCD or balloon. But nowadays, most of the people do not give any of the barriers, and we simply put the patient on estrogen for next 1 to 2 months, and it has been seen that it prevents formation of any adhesion in between. There was a very good paper which analyzed the reproductive outcome in the patients with septa before septal resection and after septal resection. Before the septal resection, the miscarriage rate was 88%, and after septal resection, it was only 14%. Similarly, preterm delivery was 9% before septal resection. After septal resection, it was only 6%. and live birth rate improved from 3% before resection to 80% after the resection. And that is why it is now recommended, as soon as the patient is diagnosed with infertility and you diagnose the septa, before treating her with for infertility, you should remove the septa so that her first pregnancy is going to turn out to be a term pregnancy and a good live birth. Then comes the endometrial polyp. It is also one of the most common findings in infertility patients. It is a localized hyperplastic overgrowth of gland and stroma of endometrium, and it has always got a feeder vessel. It is being seen in about 15 to 24% infertility cases, and hysteroscopic polypectomy has been found to improve fertility and increase pregnancy rates irrespective of the size, number, and site of the polyp. So, and it is also very easy to diagnose either with a simple transvaginal sonography, or one can do a sonosalpingography and diagnose polyps very well. So you can see a beautiful polyp hanging inside the uterine cavity, and it is quite easy to remove it with just simple cold scissors. You can cut at the base of the polyp, and the polyp, as the polyp remains attached with a very thin stalk, take out the scissor, put in the grasper, and catch hold of the polyp and just avulse it from inside the uterine cavity and take it out. So it is very easy to perform, and it gives a very good result. After hysteroscopic polypectomy, the outcome of clinical pregnancy rate has been found to have increased to 63% from 28%. Live birth rate is also significantly increased. There are various reports which say that, and miscarriage rate is reduced. So it is a strong recommendation for removal of polyp in all infertile women. SOGC in its guidelines of 2024 also says that hysteroscopic polypectomy to improve reproductive outcomes is recommended in patients attempting unassisted conception, ovulation induction, or even mild ovarian stimulation, and it has been proved to improve fertility. Then comes submucous myoma. It is found in about 20 to 40% of women of reproductive age, and submucous myomas are 5 to 10% of all uterine fibroids. It has great impact on fertility and needs timely diagnosis and management. Hysteroscopic resection is the method of choice in the treatment of intrauterine submucosal fibroids. And whatever may be the number, you can remove either in one sitting, or you can take 2 or 3 sittings to remove the uterine fibroids. Although to remove submucosal fibroids bigger than 2 to 3 centimeter, one should have a great expertise and experience in doing hysteroscopic surgery, because doing submucosal fibroid removal has been found to have maximum number of complications in the form of fluid load when monopolar cauterization, monopolar loops were being used. And that is why nowadays we are doing with bipolar loops, where there are less chances of fluid intoxication, but still we should have a watch on the intravenous fluids, even if it is normal saline or Ringer's lactate, because water intoxication can still occur. So I'm unable to show my video of submucosal fibroids. I don't know why it is not being projected. Nowadays, in place of removing the fibroid with loops, myoma shaver has come out, and that is, I think, very easy to use, because myoma shaver is an instrument which simply is pushed into the uterine myoma, and it is rotated, and gradually, like the morcellator, it goes on breaking up the myoma and sucking out the tissue at the same time till you end to the surface of the myoma. So what type of submucosal fibroids and you can remove by hysteroscopy? Type 0 to type 2. Type 0, you can see this is a type 0 fibroid only attached with a pedicle to the uterine wall. This is the most easy one to remove, but you should always start from the top of the fibroid and then go to the polypoidal base of the fibroid. Otherwise, it will be difficult to remove. In type 1, it is also not very difficult. You can gradually start from the top and go to the bottom and try to take out the myoma completely, never leave behind any part of the myoma. In type 2, the less than 50%, more than 50% inside the cavity, but still you can remove it at one setting. You remove partly the myoma, then create a negative pressure inside the uterine cavity. Rest of the myoma starts bulging out into the cavity, and it becomes easier to slice it out. So, submucous myomectomy enhances fertility outcomes by restoring uterine cavity and its integrity. Conception rates post-surgery is approximately 50 to 60% in patients with infertility, which was because of submucous myoma. SOGC clinical practice lines again recommends hysteroscopic myomectomy as to be considered in patients with attempted conception, whether assisted or with assisted, whether unassisted or with ART before going for management of infertility. Then comes the intrauterine synechia. Intrauterine synechia is a common cause of secondary infertility. It can be caused by as a post-traumatic incidence after DNC and surgical termination of pregnancy, or it can also follow post-infectious severe endometritis following delivery. Post-operative adhesion formation after myomectomy can also occur, and even after cesarean section sometimes. Vaginal ultrasound already gives an indication for Sherman syndrome, but hysteroscopy is the gold standard for a correct diagnosis. So in hysteroscopy, you can see different type of adhesions. There can be complete obliteration of the cavity, where the restoration of the cavity is actually difficult. But there are very many simple cases also. In some cases, there is only adhesion at the level of the cervix, and the patient comes with amenorrhea following medical term, following evacuation. So in those cases, it becomes very easy, and there are sometimes only few bands from anterior to posterior or from lateral walls from this end to that end. In those cases, it is quite easy to do, and even the beginners, after some having done some cases of simple surgeries, can go with doing a Sherman syndrome. But in the plastered cases, actually it is difficult to do and get a good roomy cavity at the end of the surgery, and there are more chances of perforation, because we all know that in hysteroscopy, the two ostia are the landmarks from where we orient ourselves inside the cavity. Once there is complete obliteration, the ostia are usually obscured. It becomes very difficult to begin from which area to start cutting. So you should be very careful about it. But this is a very rewarding surgery to doing an intrauterine adhesion. Patient planning to conceive and known to have intrauterine adhesion should have hysteroscopic adhesiolysis to improve the likelihood of birth. And even patients with infertility and sometimes with recurrent pregnancy loss, they are diagnosed with intrauterine adhesions. And in those cases also, it is quite helpful in improving the future outcome after adhesiolysis. Then comes the foreign bodies. Sometimes there are foreign bodies inside the uterine cavity, which acts as a barrier to contraception, like intrauterine devices. And this happens mostly following second trimester MTPs in the past. And once you put it, even with ultrasound, you can see calcified areas, shining areas inside the cavity. And once you put in the hysteroscope, you can see the bony chips floating, many a times floating around inside the uterine cavity. And many a times you can see it is embedded inside the uterine wall. So it is just standing and embedded in the both anterior and posterior uterine wall. So in these cases also, removal of all the chips one by one and making the uterine cavity clear of any sort of foreign body inside, patients can have very good pregnancy outcome in the future. Then comes the isthmocele. The incidence of isthmocele can range from 20 to 70% in women who have undergone cesarean section. It is a pouch or a space in the lower part of the uterus known as the isthmus, which can lead to the accumulation of blood and fluid in the uterine cavity. 20 to 70% of isthmoceles are symptomatic in the form of dysmenorrhea, irregular spotting before and after menstruation, infertility. The risk of infertility in women with isthmocele is 4 to 19%. And the infertility occurs because of local inflammation, accumulation of fluid, bleeding from isthmocele, having a cytotoxic effect on embryo, which prevents its implantation and reduces endometrial receptivity. So you can see the isthmocele picture over here, and you can see this is the pouch of the isthmocele, and in the area of the previous cesarean section scar, it can be of different shapes and sizes. It can be in the form of a pouch, or it can be like a triangle, and all that shapes it can take. And parameters to evaluate isthmocele are: what is the residual myometrial thickness, that is RMT. That is the thickness between the tip of the isthmocele to the adjacent myometrium, the whole of the myometrium. And another is isthmocele depth from the center of the uterine cavity to the apex of the isthmocele, and the isthmocele width, that is the lateral margins, the distance between the two upper and lower margins of the isthmocele. And with this, you know whether it is a small isthmocele or it is a large isthmocele. If it is less than 3 or less than 2.5, it is a small, but if it is more than that, then it is a large one. And depending upon this RMT, residual myometrial thickness, we decide whether you should go to repair the isthmocele through hysteroscopy or through laparoscopy. So the treatment, if the patient doesn't require issue, medically you can try to treat her, but if she is anxious for future fertility, then if the RMT is more than 2.5 millimeter, we can go for resection and coagulation of the bottom of the isthmocele so that there is no bleeding in between. If this RMT, residual myometrial thickness, is less than 2.5 millimeter, then it is better to repair it laparoscopically by excising and repairing it well. Post-surgery reproductive outcome has been seen to be very much improved. More than 60% of the patients do have live birth rate in few months. And isthmocele has also been reported in ESOC journals, that ESOC journal says, and this is says that there is currently no agreement regarding the diagnostic criteria or surgical technique for isthmocele. It seems clear that symptomatic patients should be offered treatment. This can be medical in patients without a desire for future fertility, but is necessarily surgical in patients with secondary infertility. Then comes T-shaped uteri. Sometimes we find in hysterosalpingography picture like this, very narrow tubular cavity. In this patient, lateral metroplasty is needed to enlarge the cavity and have a good future pregnancy outcome. Unicornuate uterus is the most dangerous type of uterus. In this, the patients do have early abortions, preterm deliveries, midterm deliveries, preterm deliveries, and infertility also. And it is also recommended, many people do it, and there are good reports regarding the improvement in the fertility potential of these patients by just enlarging the cavity by putting just incising upon the lateral wall so that the cavity is enlarged to some extent. In these cases, you can put in balloon catheter quite for some time to keep the cavity distended so that there is epithelialization and the size of the cavity gets enlarged. So you can see the lateral metroplasty is being done in case of unicornuate uterus so that the patient can have more chances of successful pregnancy in the future. SOGC in its guidelines says that hysteroscopic correction of Mullerian anomalies should be limited to septate and T-septate uteri unless functional or pain concerns are present, as in cervical agenesis, obstructed uterine horn. These are not recommended. These are for mostly you can do in cervical agenesis, you can take help of hysteroscopy along with the laparoscopy and go for the surgery, or obstructed uterine horns are dealt with laparoscopy. In proximal tubal blockage also, there is role of hysteroscopy and you can do tubal cannulation, and in few cases you can get good result and make the tube patent. But it is not so common to have very good result in these type of cases. And nowadays, with the prevalence and such a high success rate of IVF, these procedures are not much practiced. NICE clinical guideline says that for women with proximal tubal obstruction, selective salpingography plus tubal catheterization or hysteroscopic tubal cannulation may be treatment options, because these treatments improve the chances of pregnancy in the future. Then comes the other conditions like subendometrial PRP injection that is being nowadays practiced for improving endometrial receptivity, in which there is very thin endometrium. Especially people who are doing ART are using these procedures. Chronic endometritis as a new entity which has come up. Chronic endometritis is also supposed to hinder fertility by causing chronic inflammation and poor endometrial development and lowering endometrial receptivity. Chronic endometritis can only be diagnosed with the help of hysteroscopy. Several criteria have been set up for looking at chronic endometritis. They may be present in the form of multiple polyps or increased vascularity in certain areas. There are other criteria also. And it is histologically, after taking a biopsy, it is histologically confirmed by looking at the increased number of plasma cells presence in the histopathology. And after treatment of endometritis, 2 weeks treatment with doxycycline, it has been seen that the endometrial sensitivity improves and the patients have a good pregnancy outcome following that. Similarly, arcuate uterus is controversial. Some people do not do anything for arcuate uterus because many a times we have seen in cesarean sections that even patients with arcuate uterus conceive quite well and no problem. But if the patient comes with infertility and early pregnancy loss, then arcuate uterus can also be, cavity size can also be improved by incising upon the near the fundus of the uterus so that the 2 fallopian tubes may be visible in the same line. So these are the controversial issues not having been recommended for many of the societies, but still it is being practiced. Maybe in the future, they can come as a recommendation for fertility enhancing surgery. Thank you very much for patient hearing. Hello.
Thank you so much,
It
ma'am.
was excellent.
It was an excellent talk,
Yeah.
especially that you have nicely highlighted about the, ismosil. This is really a problem. Probably many of our gynecologists are now we are aware of that. And then many cases of infertility, post-cesarean cases, we cannot find anything that might be a very important cause of infertility. We should be careful about that. Thank you, Dr. Anita. I think it's a very beautiful discussion. Very precisely, we have told so many things. Thank you very much.
Thank you, Anita Madam, for the beautiful discussion on hysteroscopy. Really, even with transvaginal 3D ultrasonography also, we can miss sometimes something. But by hysteroscopy, we can directly see it and we can do the treatment as early as possible. So it is really very helpful. And thank you so much, Madam.
Thank you.
Anita, it was excellent, your talk. It covered almost everything. Only thing is, I always have little doubt about these dysmorphic uterus, whether they need correction or not. T-shaped, Y-shaped, I-shaped. Because sometimes, the diagnosis is also difficult. But I agree with you that majority of infertility specialists will say that they need correction. What do you feel?
Uh, I have seen cases of unicornuate uterus. I have seen, actually, I had one patient with unicornuate uterus. So she had preterm labor, you can see late miscarriage at about 6 months. And that patient, after lateral metroplasty, in the next pregnancy, she could go up to 32 weeks. So that is one experience that I have got, maybe because of the lot of, I had started with progesterone, this and that, everything I did for her. I put in a cervical suture also, and then she went to 32. Whether it was simply lateral metroplasty or those supporting treatments that helped, I'm not sure. But the literature doesn't recommend
Yeah,
lateral
especially for
metroplasty.
unicornuate, the correction is very, very difficult. I mean, it doesn't usually work out.
Yes.
But I was talking about the dysmorphic ones, the T-shaped and the Y-shaped, because sometimes the diagnosis also is so difficult, whether a 3D ultrasound or a
Yes.
hysteroscopy. Yeah.
So if very well done, I think 3D is better for
Yeah.
T-shaped uterus than hysteroscopy. In
Yes.
hysteroscopy, you just see a tubular tube. You do not know whether it is because of the adhesions, past adhesions, or it is what. But in 3D ultrasound, you look at the thickness of the lateral wall of the uterus.
Yes.
If the lateral wall of the uterus is quite thick, then of course you can go for lateral metroplasty
Yeah.
without fear of getting any perforation in that. But
Absolutely.
just because now people are doing with cold scissors all these enhancements of the cavity, it is not very dangerous, and I think one can try with that. And maybe in the future they come out with a series of more and more number of cases, and let us see what happens in the past. But up till now, there is no recommendation from any of the renowned societies.
Yes, exactly. Because the scientific evidence for correcting this dysmorphic uterine defect has not been to the greatest level. We hardly get case studies reported by few of the centers, and that's where we have to concentrate and take it forward. We have to prepare our own cases and repair success rate that we have in our individual cases, then sum it up, and then only I think we'll be able to come up to a particular conclusion what is best for our group of people.
Absolutely. Where
Yeah,
these
Um,
dysmorphic are
Anita
concerned, I
madam.
find it most difficult to make the correct diagnosis. 3D will give you a
Right.
feeling that yes, it is Y-shaped or T-shaped, but when you're doing a hysteroscopy, you are not absolutely sure.
No. So I
It has to be a
think few
it has to be a
indications 3D
combination.
is superior to
madam.
It has
hysteroscopy.
a combination, basically combination of
Yes.
3D and a hysteroscopic correlation.
Yeah.
Jata
Anita
madam,
ji,
I think
I
I
must
go
say
with the
it
clinical
was
history. Sujata ma'am, I go with the clinical
yes.
history of previous abortions,
Yes.
history of preterm losses, history of IUGR. These are the cases where there is no living issue in the past. These are the cases where it might be helpful because of adhesions or shape, dysmorphic shape, that is important.
Yeah.
Otherwise, being a hysteroscopic surgeon, so many times we get tempted to correct these T-shaped uteruses.
Absolutely.
Those patients with history of IVF failures, in many of the centers, it's a protocol to do fundal and lateral metroplasty.
Yeah.
What is your view about, Sujata madam, what is your view about that?
That is what I was mostly asking. I don't agree. Actually, I do not know because the literature is very, very inconsistent out there. So we don't have clear guidelines. Whether yes, just day before yesterday, I saw a video by somebody from Europe who's very well known. I can't get his name suddenly. He was showing a very nice, properly resection and correction of a T-shaped uterus. And if you actually think about a T-shaped uterus without a laparoscopy guidance, you really do not know. If you don't have an ultrasound guidance also at that time, you don't know how much you're cutting, what you're cutting, and laterally also, if it's a Y-shaped uterus also, how to cut, how much you cut. And it's so thick with an Y-shaped uterus. It's not like a septum. think about a Y-shaped. But that's why I am not very sure what to do about these patients where IVF failure is concerned. When you're doing a pre-IVF hysteroscopy, by chance, if you feel that a uterus, this looks like a Y-shaped uterus, then whether you should correct or not, some people have such deep cornua and deeply placed, high up placed ostia both sides, and that makes you feel, yes, this looks like a Y-shaped uterus. But whether that needs correction or not, and then how much to correct, how to correct, these things I think are many questions, at least in my mind.
Yeah, routinely people are doing in India, but I think we should go methodically and we
Yeah.
should publish the research papers, doing maybe a case study of 50 to 100 cases, and
Yeah.
then we can come to a conclusion. But otherwise, if you see unsupervised, everybody is doing it.
Yes.
Yes.
I
Yes.
I think
Arun
there's a
sir,
big
Arun sir, what
question
is
mark.
your view about this?
Yeah, that is what actually I wanted. There are no scientific recommendations to go ahead and do it. But yes, the scientific recommendations will come only when we start doing it and publishing our own reports. So maybe the IAG can take it up on those centers who have a high volume, or those hysteroscopic surgeons, those who are doing it on a regular basis, can report on a specific time period, and let this be one study from the IAG itself, whether lateral metroplast is suitable for our subcontinent or not. Otherwise, presence of an T-shaped uterus reported on an ultrasound or a particular hysterosalpingography doesn't need correction as far as I'm concerned. And one more important thing that I would like to push forward as far as your tenure is concerned, I think people today are doing hysteroscopy under general anesthesia. That's what actually I'm little against. I want the people to see the patient. If they see themselves what sort of defect they have, they get convinced. And doing an office hysteroscopy is possible, feasible, and it all depends on our mindset, whether we can take this patient with little amount of counseling. And to be honest, as far as I'm concerned, 95% of my hysteroscopies are office procedures, including the surgical ones.
You're absolutely right, and it's a very good thing you brought this up. Even I am surprised so many people are doing it under anesthesia, general anesthesia. I'm thinking, Arun, here the situation, Kalyan might also, I don't know whether you'll agree or not, Kalyan, but the thing is that many people, it's about expertise, how quickly you are able to go in and come out and make a diagnosis or make a office-based procedure based on your capabilities. So that is the time when they do it under anesthesia, because, you know, it will take time, they'll take a little extra effort. I'm not sure, but it is very, very disheartening to see that a lot of hysteroscopies are being done, even diagnostic are being done under general anesthesia.
And that's what we want to emphasize, that initially hysteroscopy was not done. Now people are doing it routinely. Now we have come to a conclusion that we should start doing office hysteroscopy. The counseling of the patient is very important. Patient needs to be in real control, talking to her for 15 to 20 minutes prior to the procedure. While you are doing a procedure, you need to talk to the patient. And the counseling part is very important in office hysteroscopy. As a IAG, we are conducting 5 office hysteroscopy workshops in Tier 1 cities. Till Tier 2 and Tier 3 cities are not ready, but if Arun sir is willing, I can take one at your place so that it will be beneficial for
definitely.
each. My team will contact you, sir, for the office hysteroscopy workshop, and IAG sponsors 50,000 rupees for these workshops to do this, so that no expenditure to you.
And
Definitely.
also how to enhance the skill of the gynecologists who are starting to learn this. Only then they will be comfortable and not do it under anesthesia.
No, ma'am. Firstly, routinely they should take a training, proper training.
Yes.
Second thing is virtual parameters have come now, that they are doing virtually on laptop. And a laptop and AI with additional is going to tell you whether you are going in right direction or wrong direction. And then accordingly, AI is going to help you to learn hysteroscopy properly.
Yeah.
For that, we have IAG Academy of Hysteroscopy started this year. And we have one course next week that will be in Bangalore, and after 1 month in Mumbai. So anybody can join for these academic courses so that they can learn proper hysteroscopy with lectures, online modules we have, and they have to pass these modules before they go in an operation theater, ma'am.
Fantastic. Fantastic.
So thank you, Anita ma'am, for this lively interaction and good topic covering all aspects of hysteroscopy, fertility enhancing hysteroscopy. And we are thankful to you from bottom of heart for this academic exchange of the knowledge, ma'am. Thank you so much.
Thank you, Kalyan. Thank you, Dr. Sujata
Thank you.
and Dr. Barua for the lively discussion following the lecture. Thank you very much.
Thank you.
Thank you.
We are following your
Thank you.
footstep only, ma'am.
Over to Dr.
Thank-
Monica and
thank-
Shatabdi for next session.
Thank you, Sujata ma'am and Arun sir, for staying back with us for the academic session. And thank you, Anita ma'am, for such an elaborate talk. I am sure all the faculties who have joined in for the next panel discussion, their job is a little easier now because sir is going to talk about difficulties in hysteroscopy and complications. So we move on for the panel discussion. And Kalyan sir, we wish you all the very best for all your future endeavors in Foxy as sir is contesting for the West Zone Vice President. And we also wish Dr. Prerna Kishan best of luck because she'll be contesting for chairperson as YTP committee.
Thank you.
And thank you. So we move on to the panel discussion. Shatabdi, will you be able to introduce
Yes,
the
yes.
panelists
Yes, Monica.
and our expert,
Yes.
Hafizur sir?
Yes.
Thank you so much.
A very warm, happy Dasara to all of us. Let us all have a great year ahead. Very, very nice talk by ma'am. And as Monica said, I think the job of the panelists will be much easier now because sir will be dealing with the complications. So we have a very interesting panel on complications of hysteroscopy. It will be moderated by Kalyan sir. Our expert for the session is Dr. Hafizur Rahman. Can I have the CV, Shivani? Yes, Kalyan sir, we have introduced. Yeah. Dr. Hafizur is a professor in Obs and Gynae. He's the governing council member of the Indian College of Obstetrics and Gynecologists. He is also the secretary of the Sikkim Obs Gynae Society. Welcome, Dr. Hafizur.
Thank you.
We have a very good mix of panelists over here. We can move on to the next CV, Shivani. Yes, yes, Dr. Gopal CV. Yeah, our first panelist for the day is Dr. Gopal Kalita. Sir is one of the senior consultants in obstetrics and gynecology. He is the medical director of Sushruta Hospital at Nalbari, Assam. And he's been practicing infertility and laparoscopy for the past 25 years. A very warm welcome to you, sir.
Thank you.
Our next panelist for the day is Dr. Ruby Bhuyan, ma'am. Dr. Ruby is a senior consultant in Obs and Gynae. She has a professional experience of over 35 years in medical colleges and district hospitals in Nagaon and Kamrup district. She's life member of IMA as well as Foxy. Welcome, Ruby, ma'am. Our next panelist is Dr. Yashodhan Deka. Dr. Yashodhan is one of the senior consultants in advanced laparoscopy. He's currently a laparoscopic surgeon at Nalbari Maternity Hospital and Sarathi Hospital. And he's also has been an operating faculty in various national and international workshops. A very warm welcome to Dr. Yashodhan.
Thank you.
Our next panelist for the day is Dr. Prerna Kishan. Dr. Prerna Kishan is the East Zone leader for YTP Foxy as well as the Yuva coordinator of Foxy and a member of Breast Committee of Foxy. She has been awarded with various national awards and has been an invited speaker in over 300 zonal, national and international conferences. Welcome, Dr. Prerna. Our next panelist, yeah, Shivani, next slide, please, is Dr. Lungan Rongmei. Dr. Lungan is one of the associate professors in the Department of Obstetrics and Gynecology at AIIMS Guwahati. She has a fellowship in minimal access surgery from Ahmedabad, and she also has completed a hybrid fellowship hands-on colposcopy training from Mumbai. Welcome, Dr. Lungan, one of the young people in the panel that we have.
Yes, ma'am.
Our next panelist, yeah. Can we move on to the next slide? Is Dr. Neerja, ma'am, a very, very active member of East Zone in various committees. She is the consultant in Obs and Gynae at Digboi CHC. She has been trained in TOT in Medley APR as well as MAS. Welcome, Neerja, ma'am.
Thank you.
Our next panelist is Dr. Himleena Gautam. Dr. Himlina is an associate consultant at Apollo Hospitals in Guwahati. She has also been trained in laparoscopy and reproductive medicine as well as colposcopy. And she is an active member in various societies like IMA, FOXY, GOGS, etc. Welcome, Himlina, Dr. Himlina, ma'am.
Thank you.
Yes. Can I move on to the next slide? Yeah. Our next panelist is Dr. Pratibha Pasari, ma'am. Ma'am is a senior consultant and IVF specialist at Apollo Fertility at Guwahati. She's also the joint secretary of the Guwahati Obs-Gynae Society and ex-secretary of ISOPAB Assam chapter. Welcome, Pratibha, ma'am.
Thank you so much.
Yeah. Can we move on to the next slide?
Done, ma'am. Over.
Yeah. Okay. So that was a very good mix-up of panelists, I would say. Over to you, Kalyan sir. Looking forward to a very interesting
Yes,
discussion.
can I share my screen, please? Thank you. So we have a lot of experienced panelists, and I'm going to talk on a topic that is hysteroscopy complication, what must have gone wrong while you are doing a hysteroscopy. As you know, diagnostic and operative hysteroscopy are relatively safe procedure than laparoscopy. Majority of the complication occurs because of the ignorance of contraindication, poor surgical techniques, inadequate knowledge, and wrong application of instruments. Diagnostic has around 0.13% complication rate, and operative has around 1% complication rate. We are going to talk in this manner: perioperative complication, complication because of the positioning, intraoperative, distension modia, post-operative, and delayed complication. So now my first case, this is a 25-year-old lady, known case of primary infertility since 4 years. Patient posted for hysterolaparoscope. The operator is doing a hysteroscopy. For 2 to 3 minutes, he can't find the ostia. He has put a valcellum and then tried to negotiate the passage. He can't find the ostia at all. So this is a case of failed hysteroscopy. So now anybody can take the question, what are the causes of failed hysteroscopy or going into the myometrium instead of the endometrial cavity?
Most of the failed
Dr. Prerna.
hysteroscopy.
Yeah.
Thank you, Kalyan sir, for this opportunity to be here, and our heartiest best wishes for your next endeavor. And
Yes.
this question is pertaining to failed hysteroscopy, maybe because of majority of them, because of maybe cervical stenosis or no preoperative preparation was not good. Maybe the cervical dilatation they have not taken care of, and mostly because of acutely flexed uterus. Also, at times it can happen. So usually there are cases where there can be a false passage can be created in such a situation where you keep on finding the ostia. So there we need to be careful about. So most importantly, it is cervical stenosis or maybe because of the flexion of the uterus, which is acutely towards the anterior end.
So how you are going to manage this case? Dr. Lungan.
Thank you, sir, for this opportunity. As ma'am has already said, sometime it may be due to the cervical stenosis. So in case if it is a cervical stenosis, then we have to do a preoperative softening of the cervix. So for that, we can give misoprostol tablet, maybe 400 microgram vaginally 4 hours prior to the OT operation, before we start the operation. And second alternative is we can use some like mechanical dilator like laminaretent overnight before the procedure, the 1 day night before the procedure. And sometime during the procedure, if the issue is because of the retroverted or antiflexion of the uterus, then what we can do, we can apply some valcellum on the anterior lip of the cervix, and we can keep little bit of traction so that it become aligned with the endocervical canal becomes straightened. So as we negotiate the cervical os and enter the cavity, we can remove the instrument, and that's how we overcome the problem, sir.
Very rightly said by Dr. Lungan. It's acutely antiflex, plays a long-bladed pulsus speculum, and it pushes the fundus in the mid position and can facilitate dilatation. In case of retroflex uterus, place a tunaculum on the posterior lip of the cervix. Apply the traction so that it becomes straight. And rightly said, misoprostol can be used. Sometime intracervical injection of vasopressin diluted can be used at 4 and 8 o'clock position. So you have tried everything and still there is a cervical stenosis. So how you are going to manage the case?
If I have never tried this, but going through this panel discussion, I got to learn that we can give some cruciate incisions into the os, identifying where is the os. We cut a cruciate shape into the stromal part, and then we can use a dilator to negotiate the obstruction, sir.
Okay. Any other methods you can use, Dr. Nirza or Dr. Himlina ma'am?
Yeah, while going in through with mild synovitis, like we use a small hysteroscope, but that can also be done.
Yes,
Ultrasound guided also, we can try inserting the smaller sounds or maybe a catheter. We can try and see the exact where is the os going, and once we identify then arterial dilatation.
Doing a good PV examination, knowing whether it is acutely anteverted, acutely retroverted. Secondly, putting a miniature hysteroscope, rightly said, ma'am, 2.9 mm hysteroscope. Thirdly, you can go with a sheath and start using a grasper forceps, go in, open up, and come back. If there is any thick mucus or some fibrotic bands which can be just broken and you can come out. And lastly, like this, you can use this hysteroscopic scissors to cut. But in this, you have to know the exact lining of the cervix and internal os. You should not perforate it. Okay, that is very important. So, Dr. Pratibha Agrawal, ma'am, any takes on this?
Sir, we have come across this situation many a times where if we are not able to negotiate, we do all the maneuvers, we pull the cervix and then firstly put the sound to know what is the direction of the uterus, and then we bring the uterus to the correct position, and then when we advance the hysteros, so as we advance, and then many a times we come to know the right passage, we are able to see that the dark circle we are looking for, and it's very rarely that we are not able to do the procedure. So with all
Dr.
the maneuvers, we can do
what
that.
we can also do is we can use a smaller Houdini scope also. If you can see a tiny hole, nowadays you have the 18 French, even the 16 French scopes. So if you have that is really helpful at times. Otherwise, if it's very difficult, then it is better to abandon and take her up again instead of doing any complications.
Yeah. Can you use ultrasound machine in the OT? Anybody thinks over that?
Good evening, sir.
Yes. Dr. Nirza, ma'am.
Yes. Actually, when I first started doing hysteroscopy, it was very scary. Scary in the sense because taking that instrument, and there is always a thought block in the operating surgeon itself. And many times I faced false cervical stenosis. I mean, it is because of the technical fault of the surgeon. So when we are first starting, having experts with us, cervical stenosis is very rarely seen. If we can do the vaginoscopy properly with a prior PV examination getting, and also if the sonography is available, a lot of information is already taken prior to the procedure. And having the expert, and of course sometimes if we cannot manage, having somebody with you also gives a lot of confidence. And sometimes even after all this things we cannot do, we can use bedside ultrasound, which will help us to locate exactly. It won't be a blind procedure. We can exactly locate and go in that way.
Yeah, very rightly said. You can take help of ultrasound if you feel that you are not getting that enough passage right. And Dr. Agrawal, madam, what is your view about using, if you negotiated the external os and now you are inside the uterine cavity, you find adhesions at the internal os. How are you going to manage this, ma'am?
I would try to advance my hysteroscope to see if I can go inside, and if not, I would go step by step, very little by little with my seizures. I would try to break the adhesions and then move ahead.
Okay, very rightly said. You need to use cold scissors and go millimeter by millimeter, and then you can finish off the surgery. The ultimate endpoint is looking at both ostia from panoramic view. And if you're done adhesiolysis, your scissors should move in from one ostia to another ostia without any hindrance. Most important, you have to have an imaginary 3D cavity of triangular cavity of hysteroscopy to be formed whenever you are doing a procedure. Now, Dr. Himlina, you are doing this procedure and using the valcellum, and it turns off because of the excessive manipulation. How are you going to manage the cervical lacerations?
Because if it is torn off, like I'll have to assess like whether it will stop on its own or do I need to suture it. So if it is a very bad laceration, I will definitely need to suture it up. And
Right.
sometimes with pressure, sometimes it stops. Small tears, it do stop, but I would prefer taking a bite rather than leaving it. And
Right. So the
sometimes
best
putting a pack also helps for
Yes.
some times.
Yeah. So the best technique is no touch or technique, or by vaginoscopy you should
Vaginoscopy.
start doing. So that any takes on this, Dr. Deka, of vaginoscopy?
So I
how
think
to
if you
go
have
a
a
bit of-
if you have a resectoscope with you, then immediately just put in the resectoscope with a vaginoscopic approach. Just use the quag mode of the machine and just superficially you can coagulate the bleeder. Very easy, because sometimes it is even very difficult to take a stitch. Sometimes the cervix is so short and the tear is at a very uncomfortable position to stitch at once sometime, because the bladder hold is also nearby. So you can just quickly take a resectoscope and use your, even if you don't have the roller ball, you can take the loop also and coagulate it. It stops immediately.
Yeah, cervical laceration nowadays is very rare because we are doing vaginoscopy and so
Preparation,
many are not done. Yeah, now this is a second case, Dr. Prerna, 35-year-old lady, primary infertility with cervical stenosis, planned for IVF, and IVF specialist is unable to pass the ET catheter. So she referred back to us, my friend from Hyderabad, and now you can see the video and come to a conclusion. What you see in the video, any abnormal foreign body, what must have gone wrong, and how would have you managed this case, the primary case of hysteroscopy, because she has undergone hysteroscopic adhesiolysis at one of the centers. She was a case for refer for IVF.
Usually, this case should have had a pre-transfer hysteroscopy, a
Yeah.
trial.
Something at 5 o'clock, 7 o'clock.
Foreign bodies.
Right. So it is a tip of the bipolar they found inside, and the video shows broken tip of needle of bipolar electrode. It was removed. The tip of electrode is very thin and can be missed. So it is important for the staff to check at the end of the procedure, everything is fine or not. So, Dr. Prerna, you should start washing your instruments on your own, then giving to staff, because she may miss it and it can remain as a foreign body and it's a negligence on our part. Okay. So now coming to Dr. Niza. Now, this has happened to me, one of my patients. We did the surgery. On the day of discharge, she was walking like this. So, she has a foot drop, Dr. Niza. What are the causes of foot drop and what is the complication?
Yes, sir. This is one of the complications not related directly to hysteroscopy, but because of positioning. And this may occur during any procedures that we do when we place the patient in a lithotomy position. This is due to injury, due to the perineal nerve. So there is a foot drop. The leg was flexed in a wrong way, and maybe the cushioning was not done properly. Procedure might have taken some time. So as a result, there was nerve injury. So it is very important that we take care of the smallest details, like before even doing the procedure, like whether the patient is comfortable in her position, her hip is slightly flexed and abducted, externally rotated, whether she has been put on cuffed pads below her thighs, and the idea is whether she is comfortable before we start the procedure, and not just jump into the procedure like having an array of patients trying to do it fast, like that will lead to more complications.
Very rightly said, Dr. Nija. Dr. Lungan, you want to add something?
No, sir, as ma'am have already said, like this foot drop is very common because of any operative procedure that we put patient in a lithotomy, even in vaginal hysterectomy cases or any operation that we need to put in lithotomy is very common. So as nowadays new things are coming up, like with a good cushion system, sir. So we can put like cotton pad where it is not available, like the thing, ma'am. That's what, sir.
Yeah, so nerve injuries, foot drop, deep vein thrombosis, and even back injuries, they can happen. Saphenous nerve, peroneal nerve, and even femoral nerves can damage, and this can happen when you are given a general anesthesia. So that can happen, and this modified lithotomy position is most ideal. Moderate hip flexion, limited abduction and external rotation. Use padded Allen stirrups so that you can avoid. Now, Dr. Deka, we are doing this hysteroscopy, and I see intestine inside.
But then immediately we have to put in a scope and see. If it's
I
a
have
cold,
not started my cautery. Only during the hysteroscopy, diagnostic only, we found that. So we have put a hysteroscope. So it is ideal to put laparoscope every time?
not
Or you
every
can
time, sir.
just observe.
If it's with a cold scissor, we can wait and observe. But definitely with an energy source, we have to put in a scope to see for any secondary injury to the bowel. And if you see that the hemodynamics start to fluctuate, then definitely you have to put in a scope. And if you have an ultrasound machine in your theater,
very rightly
nothing like it. Yes,
but you know, ultrasound has slight problem that hysteroscopy fluid and this blood can be misleading.
No, so what we can do is we can follow up the depth of fluid in the POD and say we follow repeat the scan again after half an hour or 45 minutes. At the same time, keep a check on the patient vitals.
Right. So this patient was for laparoscopy also because of infertility. So we could put a
Good.
laparoscope.
Lucky day for you, Sobhan.
Right. So uterine perforation while doing a hysteroscopy is seen in 14 per 1,000 according to the AAGL survey. Perforation is more likely in repeat procedure. Electrosurgical devices causes thermal injuries. Following perforation can lead to peritonitis, sepsis, and death. Now I want to know what are the tips to avoid the injury or perforation. Anybody can take this.
Dilate the cervix very slowly with a steady pressure.
Very rightly said.
And
Yes.
also, we shouldn't use dilators that should be that push towards the fundus. That is very wrong. And also hydrostatic
once you reach
dilatation.
the internos, just stop there. You know, people have a habit of pushing it too far, right?
Hydrostatic dilatation can also be used.
Yes.
And they can insert the hysteroscope or the resectoscope under direct vision rather than keeping searching around for the circle, dark circle around here.
Dark circle. Very rightly said. So to wrap up, simple perforation, just observe. It's complex perforation. Evaluation of bowel injury is very important. If injury is identified, Dr. Deka sir, have you observed any of these such injuries and how you manage these bowel injuries?
Luckily, I haven't had a situation where we had to.
Maybe some patient may refer to you or something like that.
Yes, for thermal injuries, we don't have a choice. So what we do if the thermal injury is small, nowadays we do a discoid excision. Otherwise, if it's a large one, then better to do a segmental dissection. If it's just a blanching, then we just stitch it in 2 layers using PDS 30 nowadays. That at least gives us adequate support for the next 6 weeks or so. But if it's a very obvious burn, very recently we got referred a case after a DNC. where we had to do a laparotomy because she had bowel injuries at 2 places. So we had to do resection and anastomosis. But very dangerous situation.
Very rightly said. Yeah, anytime, please search the bowel completely.
Yes.
If you're not comfortable, get a surgeon's help. It will
Do
be
a
helpful for
laparotomy
medical.
and check. Yeah, don't be shy of a laparotomy
Even
because
if
it will save
Dekha
the
sir is
patient's
doing
life.
this surgery independently, yeah, that is, even if he's doing it independently, it's always better to keep a surgeon standby so that
Absolutely,
bowel
sir.
thing can take place, right? And then accordingly, if you have any bowel injury, please observe this patient for 48 hours or more time in the hospital. And once you are comfortable, then only you can discharge these patients. So complex.
Yes, and now if I feel that if the patient is from very far, ask the patient to stay around with you for 2 weeks.
Right.
Because
Very right.
thermal injuries can manifest as late as 2 weeks also. So keep the patients nearby. You can repeat their total counts and CRP every alternate day. And only after the patient passes 2 weeks, you should send her off.
Very rightly said, doctor. So now we come to Dr. Hafizur Rahman, who is an expert. Can you just guide us, sir? Anything is remaining in this?
No,
Dr.
sir. I think it has been very nicely explained, and whatever all the panelists have said. But I'd like to say that is the perforation, because sometime I have seen in complications, as it was saying, there's even Yashodhan has also said, if there is with energy sources, because I have seen cases by even when it was doing expertly, injuries in multiple places of bowel. And that is the time. So the first, it is a sooner decision to do a laparotomy and then see thoroughly. And obviously, it's very essential to see and observe the patient for a longer period of time, because once the patient goes or it is delayed in diagnosis, there has been some catastrophic outcome. So it's always in case of with thermal injuries, it is there. But obviously, with like laparoscopy is always not needed, because that is, I have also seen using scissors, some time perforation, and usually there is no problem when the patient is observed for maybe 24 hours or 48 hours. So that is first the thing. Whenever there is thermal injuries, one should be very liberal in doing laparoscopy, and if required, maybe for early decision of a laparotomy and thorough search for the bowel injuries.
And firstly, thank you, sir, Dr. Hafizur. We should accept that some complications happen. Patient safety is important, because on the table you can manage everything. It's not important, or you should not have some ego. And any complex injuries, you have to involve any of the other hysteroscopic surgeon or laparoscopic surgeon or surgeon.
Even sir, doing for diagnostic laparoscopies also, sometime doing hysteroscopy, and some might think whether the assistant or somebody is thinking if there is a doubt in even doing for a laparoscopy is required, then it should not be like that it's okay, everything is okay. It is required for thinking laparoscopy, because many times patient is in the operation theater, they may have to require depending on our instrument which may have the injuries there. So that is also required. That is, one may decide early without having any ego, just like you are saying.
Right. Very rightly said by our expert, Dr. Hafizur Rahman. There should not be any ego in operation theater. You are a student till you die.
Yes.
So now coming to the next case, that is during transcervical resection of myoma of 4 centimeter size, type 2 myoma, patients start bleeding. So how are you going to manage? Dr. Gopal sir is there?
Yes, sir.
Yes, sir.
So, sir, are you hearing?
Sir, you are audible, sir, now.
Yeah. Actually, whenever there is a resection in myoma or polyp, if there is a bleeding, we should go for electrocautery first. Then if it is not controlled by electrocautery, then we have to go for this dilation of diathermy by pressure. If it is not controlled, we can go for packing also. But after packing, we have to wait for at least half an hour to 1 hour. If there is the packing, then we have to go for the external view also. External view, there may be the perforation wall also. If it is not controlled even after by packing, or there is oozing, then we have to go for the laparoscopy. We just to look after the whether it is bleeding from the myometrium or in the endometrium or it maybe in the parametrium also.
Okay.
If not control, then we have side by side to inject some hemostatic procedures and uterine contraction medicine also to contract the uterus.
Like pause or methargine, you mean to say, sir?
Methargine will not work, I think. As per my knowledge, tranexamic acid or some other hemostatic agent I can use.
Yes, Dr. Ruby Buyan, ma'am, what is your view about procedure not completed? You are going to go ahead.
Yes, in this, if the bleeding after using the cautery and all, if the bleeding does not stop, I would like to prefer the Foley's insertion of a Foley's catheter with 30 ml of fluid inside to give a mechanical pressure.
Yeah, if uterus is
and prior to
enough, yeah.
I think what is
Yes,
very
Dr.
important.
Yes, Dr.
and
Ruby.
yes, either packing or use of Foley's catheter with 30 ml of fluid inside to as a mechanical pressure to arrest the bleeding. And prior to the procedure, we can use
vasopressin,
DNRS agonist or uripristal to decrease the bleeding, or we can increase the hemoglobin level if this hemoglobin level is low by either iron, injectable iron or anything, we can give preoperatively.
Yeah, but Dr. Yashodan doesn't agree with us. He says if you give danazol or GnRH agonist, he can't find the plane properly. Dr. Yashodan, what is your view about it?
I think what is very important is we should know in which setup should we go for a TCRM for a myoma. What is very, very important is to have a good endomat instead of a simple, cuff. I think that should not be attempted at all, because if you have a good irrigation system, if you have a good cautery system, majority of the time you will get away with just coagulating it, because these bleeders are not from the endometrium. This will be a bleeder directly from the myoma. So it will be a big, it can be a big vein at times. So all your Foleys and packing might not help. Okay, it might buy you time, but again, when you remove it, again it will open. So remember that doing a polyp is easier compared to doing a subresection of a myoma. So make sure you have a good endomat, because a good endomat will save you, because it has a constant irrigation and a suction system. So it helps to get your vision better. So immediately you can just do a coagulate. However, one has to be very careful about the pressure in the endomat. You should not have too much pressure, and you should never stare directly at the opening, because if you have to, it's a 30-degree scope. You look at the bleeder from far and then you coagulate it. Because if you try to go too close to where you have opened the vein, you yourself might cause an embolism there. So keep your pressure low, irrigation on, suction on, look from far 30-degree and just coagulate. I think it works just fine.
Very right said by Dr. Yes,
and sir, because we are in a very low resource settings. So what we do is to prevent then to cure. So to do that, we use this diluted vasopressin usually.
Very rightly said, Dr. Prerna. That is the thing which has two advantages. Firstly, it controls the bleeding. Secondly, it will decrease the absorption of fluid, which is very important thing. And Dr. Prerna has just said it rightly. Before going for any of the TCRM procedure, please give vasopressin diluted at 4 and 8 o'clock position. Second important thing is you choose your cases properly. You know, Dr. Lungan is doing initially cases, you should not do 4 centimeter. You go by 1 centimeter, 2 centimeter. Once you and your setup is acquainted, your assistant know how to give a pressure, then every 15 minutes, somebody will be telling you about how much the fluid loss and fluid deficit which is there. So all these things are very important whenever you are planning for such large myoma. And Dr. Deka has rightly said, if procedure is not completed, electrocoagulation is important. If procedure is completed, still there is a bleeding, you can find out bleeder is there. If you can't find out bleeding is not stopping, then uterine packing or even Foley's catheter can be kept. And this is a simple video how to put a Foley's catheter.
And I think so another important point is that for a 4 centimeter size myoma, we should always take consent for 2 sittings.
Step W classification or Lasmar classification, which has a scoring system according to the whether the myoma is on the lateral wall, what is the size of the myoma, and depending on that, if scoring is 1 to 4, then you tell the patient that it will happen in single setting.
Yes.
If 5 to 7, you might require 2 setting, and more than 7, you always tell to do it under laparoscopic myomectomy and not hysteroscopic myomectomy. Very rightly said, Dr. Deka. This is step W classification,
Very much important.
which is very important. Yes, sir. You want to add something?
No, size is very much important for the actually resectoscope, because for us it is more difficult to start with the 4 centimeter actually.
Yes, because what we have to understand is that 4 centimeter is just 1 diameter.
Yeah.
But a 4 centimeter myoma volume-wise is
Volume-wise-
actually is 4 into 4 into 4.
Yeah.
So it's quite big volume-wise.
Yeah, now Dr. Yashodhan is doing this procedure, and he found that assistant is constantly telling, sir, we are losing a lot of fluid. Dr.
Oh.
Lungan, how are you going to manage the case of fluid overload during hysteroscope?
Sir, like fluid overload, first thing that we have to prevent the fluid overload. So the surgical team, whoever is operating or assistant, should be very vigilant, should continuously monitor the input and output of the distending fluid media, and we have to see how much amount of fluid has exited through the hysteroscope or through your vaginal spill, or whatever amount of fluid has been spilled on the floor. So in case
So,
of fluid,
just I will want to stop you here, madam. Whether it's for isotonic or hypotonic, or both, you are worried about both.
sir, actually, I'm more worried about the hypotonic.
Hypotonic, very rightly said. Right.
It is more complication is seen in case of hypotonic, that is glycine use. Though we don't use commonly nowadays, we use normal saline only, isotonic. In case of fluid overload, we have to immediately stop. Like if the fluid deficit has come around like the threshold, above the threshold of 1 liter, that is in case of glycine, then we have to immediately stop the procedure, and then it is a multidisciplinary approach. In that case, we have to try to start oxygen inhalation, put the patient in a propped up position, and then we have to there will be a chances of electrolyte imbalance. So we have to continuously monitor the sodium electrolyte level. And then patient also may need critical care in the ICU if the condition, and we should need to give Lasix injection, Lasix for the diuretic purpose, sir.
Very rightly said. Dr. Nirza, what are the what are the factors which will influence the absorption of distension fluid? Dr. Nirza.
Yes. First is the duration of the surgery. If we are taking too long time, sometimes even in setting up the instruments, we take a lot of time. The duration increases. Sometimes the monitoring is not proper because the surgeon is worried about the procedure. So the support team does not take care of how much fluid is going on, how much fluid is coming out. The monitoring is not done. If it is a complicated surgery, and also the size of the uterine cavity also matters. More the size, more fluid will be, yeah. And how you are doing the surgery, if we are entering the myometrium more deeper, so and because it will take more amount of tissue, so that will also help increase the chance of more absorption of the distending fluid.
Very rightly said. Hypotonic solution like glycine can cause fluid overload. Intrauterine pressure more than 75 millimeter increases volume media. Depth of myometrial penetration, large blood vessel will be breached. Duration of surgery more than 30 minutes. And size of uterine cavity, larger cavity will have larger endometrial area for fluid absorption. In premenopausal patient have higher risk of developing neurological complication, and those cardiovascular, renal disease and elderly women are less likely to adapt to the sudden significant increase in the intravascular fluid. So in OT, one person should be dedicatedly seeing what is the fluid deficit. Every 10 minutes, he should be signaling to the doctor 500, 700, 1000. And that's how you should be listening to this person, because what are the hypotonic fluid overload system? Look, Dr. Lungan, Can you just elaborate in 1 minute?
Yes,
For the
sir. Hypotonic.
Electrolyte complications.
Electrolyte, yeah, hyponatremia can cause like your CNS abnormality in the form of the patient will be drowsy, patient will become loss of consciousness, confusion, weakness, and patient will have headache, nausea, vomiting because of the hyponatremia, sir.
Very rightly said. So if you are going to do a baseline electrolyte prior to the surgery, then it will be helpful for you to know whether it's a symptomatic or asymptomatic hyponatremia. Dr. Pratibha ma'am, can you just elaborate about the management of hyponatremia? Dr. Pratibha Pasari.
Sir.
Yes, ma'am.
First, we need to put the patient in ICU, manage the patient in ICU. We do all the investigations. We see the levels of the electrolytes, and then we restrict the fluid to the patient, and we give Lasix, and it's a multidisciplinary approach. So we involve all the with the if it's the CNS abnormalities, like we include everyone. We monitor input, we monitor output, oxygen saturation. We do a chest X-ray, a portable chest X-ray, so to see if the patient is having pulmonary edema. So this is how we manage.
And you are going to give 100 ml of bolus of 3% saline over 10 minutes and repeat up to 3 times, followed by slow IV infusion. And very important here, what is the anesthesia, Dr. Deka, you feel is better for hysteroscopic surgery?
So local anesthesia for a shorter procedure, and in our setup, if we are expecting a little bit longer, then even spinal anesthesia is good enough.
So
they give
what
a
I
very good low
recommend is
saddle
to
block.
give either saddle block or
Block,
spinal anesthesia, so that the patient has confusion,
comfortable,
lethargy, and patient will have this agitation, cerebral signs of cerebral irritation that can patient tell to you while you are doing the procedure, even if your fluid deficit monitoring is not that good. And for this monitoring fluid deficit, we have closed system so that they can measure properly. Automated fluid measurement system, Dr. Yashodhan has already told about this. And these are the fluid measurement system which are going to tell you the deficit. And these are the BSG ESG 2018 safety recommendation. Isotonic electrolyte containing distension media such as normal saline should be used with mechanical instrumentation and bipolar electrosurgery because of the low risk of hyponatremia and fluid overload. Hypotonic electrolyte free solution media such as glycine should only be used with monopolar. Automated pressure system provide constant intrauterine pressure, accurate fluid deficit surveillance, advantages for prolonged operative procedure. Measurement of fluid deficit should be done at every 10-minute interval. Local anesthesia with sedation should be considered for performing operative hysteroscopic procedure rather than general anesthesia. Underline this. And AHL practice guidelines for management of hysteroscopic distension media 2013. Intracervical injection of glycine, vasopressin will decrease the distension media absorption level A evidence. Uterine cavity distension pressure should be lower than the mean arterial pressure level A evidence. Excessive absorption of hypotonic fluid can cause fluid hyponatremia and permanent neurological complication or even death. Type grade B recommendation. Risk of hypotonic encephalopathy is greater in reproductive age women because of the estrogen and progesterone receptor. Level B evidence. When compared with electrolyte-free media, saline appears to have safer profile. Level B evidence. Excessive absorption of isotonic fluids such as saline can cause severe complication. Continuous and accurate fluid monitoring is mandatory. Risk of systemic absorption varies with the procedure and increases when myometrial integrity is breached. Level B evidence. So these are the very important cases in hysteroscopy. You should be aware and you should be vigilant in the OT. Somebody apart from anesthetist should be looking after the fluid deficit. Now, very interesting case. While doing a hysteroscopy, there is a sudden fall in oxygen saturation, hypotension, hypercarbia, and ECG lead showing arrhythmias. So, Dr. Prerna Keshan, what is the probable cause and how you are going to manage this case?
You've given me something very, very scary, sir. So this is every gynecologist's nightmare. So happening here is the air embolism, which we will detect, and we have to act very promptly. This patient we have to first put into the Durant maneuver, where we'll put the patient directly on 100% oxygen and give supportive treatment, and put them in the left lateral position with the head low in the Trendelenburg position. And immediately, first we have to abandon the procedure that we were doing. And this should not be the consequence of any hysteroscopy, because usually hysteroscopies are done in otherwise normal patients, not much complaints, but with fertility issues or maybe something like what we are doing for myomas and all. So they are otherwise not very ill patients that who are ending up into the hysteroscopy OT. So ending up into an air embolism with such clients is something which every one of us fear. So the immediate management is with the Durant maneuver and 100% oxygen and all the supportive measures, and abandoning the procedure. And then thereby we need to understand that how we can prevent such a situation. That is more important. And that is, we have already mentioned how we can prevent, because going through all these not
Very important,
dilating.
Dr. Prerna, is avoid repetitive removal and reinsertion of the resectoscope.
Yes.
But all the chips of fibroid fall down. You're going to remove it at the end, because what happens, you feel that the cavity is completely full, you start removing and these air bubbles start forming inside. Then you give a pressure and there can be air embolism. So use of GnRH agonist preoperatively, intracervical injection of dilute vasopressin, use vaginoscopic method, flush system with fluid to remove air bubbles, and avoid using gas producing electrosurgical equipment as far as possible. Very
So have you
rightly.
ever faced this situation?
Not yet. Dr. Lungan, you have any experience?
No, sir, I have never experienced it.
Anybody? Dr. Yashodan, Dr. Gopal, sir?
No, sir, but I think another point is that your team should be also remain vigilant on the fluid system that you're using, because a lot of times what happens is there is air in the tubings, in the pipings. So make sure that your team looks after that. And if people who don't have an endomat system, a lot of people use a normal saline, a 3-liter saline, and somebody is literally pressing on that saline. So even the assistant, even the team should have a watch on that. That sometimes you are busy doing your surgery, but your team member is very actively just pushing onto the saline. Even if it's after empty, they keep pushing it. So very small thing that can lead to a major disaster. So
Very
that is
rightly
another
said,
important
Dr. Yashodan. Rightly said. Now we are going to
Another
our
thing is that
expert.
that
Yes.
height of the irrigation fluid is also one thing that we should be from the patient's level. How much is the height of the especially for when we are applying that cuff and pressure, that height.
Dr. Himlina, we have stopped using clubs since last 10 years.
Yes, but in
And
some
you,
like in low resource.
this system, this system will cost
Yes,
you
it has to
1.2
be
lakh
above the
rupees.
height of the patient. Otherwise, the fluid is not going to come inside the cavity.
No.
They, Dr. Yashodan, previously when they used to use cuff, they used to have this height at least 6 feet high up, so that adequate distension should be happening inside the uterine cavity. But it is always safe to use system. Automated systems are important. So now we move on to Dr. Expert, Dr. Hafizur Rahman, for his expert comments. Dr.
Yes, so
Hafizur,
that is the I have never seen that is air embolism in doing my hysteroscopy, fortunately, but I have seen in other situations like that, because the deterioration of the patient is very dramatic, and there should be very much alert on that, and the active management of this patient would hopefully, with the anesthesia, would be able to do much better. But obviously, would like expect this is a preventable complication, as everyone has highlighted, and we should do our every effort in doing those small things, as like Dr. Yashodan said. Sometime especially with the pressing of the pump, it has been in small 500 ml or 1 liter, and somebody is pushing, not observing whether the saline is there, because then many times happenings in small centers or initial doing. So those are the things, small things will help us in removing these dreaded complications.
Thank you, our expert, Dr. Hafizur, sir. Now moving to the 7-number case, 25-year-old lady, 12 weeks missed abortion, underwent DNC. She has previous history of missed abortion and has now undergone suction evacuation. She comes to us with this ultrasound report after 1 month. So what is the diagnosis?
It looked like endometritis, signs of infection observed because
No, I think it's an old RPOC.
Right. It looks like a vascular pattern, which is either it can be a AV malformation or it can be a retained products of conception. So now can somebody tell me how to go about management of such RPOC by hysteroscopy? Doctor?
I think very important is to do a proper ultrasound before you go in for these cases. You map out the products properly first of all, and then again prepare the cervix well. We usually give 2 days of antibiotics and give them uterotonics, and then take the patient up. And always counsel the patient for SOS laparoscopy, because sometimes these uteruses are so soft that you perforate without even feeling the fundus of the uterus.
Sepsis profile also needs to be ruled out prior to taking up these cases.
Yes, that's why I said we always give 2 days of antibiotic prior to taking up these cases.
Admit such patient for 2 days, higher antibiotics.
Yes.
Then post these procedures. So many times the os is open, so you may not require misoprostol. And these are the patient where. Now you can see the second video. This is some cranial bones are remaining, and this patient referred to us. And you can find that I am trying to remove the bony spicules, and this must be a cephalic bone that is not coming out, and it is causing more injury to the endometrium. So in such cases, you can use hysteroscopic morcellators, because it is mechanical morcellation. It is going to eat out the tissue, and you are going to have less trauma to the endometrium, because so many times these are the secondary infertility patients. So RPOC removal is a procedure where it can cause perforation. So you have to be really careful, use your instrument judiciously, and complete the procedure in the same sitting. If required, you can use a resectoscope also if there are dense adhesions which are not removed. Sometimes they can bleed, but you should not be worried, because they are the bits of placenta and without blood supply. So this can be done by hysteroscopic morcellation. So in some part of North India, they are doing hysteroscopy at the end of the MTP or DNC. So what is your view about this? Dr. Himlina or Dr. Nirza can take this.
I think that would not be advisable. As per my opinion, I would not advise going for a hysteroscopy immediately after an MTP. As such, there will be, you have done a suction evacuation, there will be a bloody field. Inserting a hysteroscope, you may cause more injury, risk of, I think that I will not prefer doing
these days, usually we go for manual vacuum aspiration, which gives both the physical feel that the procedure is completed, and we don't have to curate the over jealous curettage of the uterus is also not done. And immediately after the procedure, another procedure, and believe that hysteroscopy is slightly more sterile, and it might lead to more, endometritis. It's just not necessary. If you are doing the DNC properly, actually hysteroscopy.
Dr. Nirza, instead of saying all this, I'll use an ultrasound probe at the end of the procedure.
Yes, that is what, like,
more
get
important
an
than
ultrasound immediately and see if anything is left.
Yeah, we have ultrasound in the OT complex. So just put an ultrasound so that you prevent this RPOC, which is dreaded complication, can cause uterine bleeding, pelvic pain, fever, uterine tenderness, if there are a lot of tissue remaining. So always better to use ultrasound. And if you find something is remaining, you can do ultrasound guided curettage.
Another situation that makes sometimes RPOC is very complicated is if you have a submucous fibroid and then the patient has taken tablets and come to you. So
Right.
very tricky because old RPOCs, sometimes they mimic a submucous fibroid, because we get a lot of referrals where a patient has undergone DNC twice, thrice. And you would be surprised the number of times we have found it's a submucous fibroid instead of an RPOC. So very tricky situation.
Very rightly said, Dr. Yashwadan. And another complication is infection, post-operative adhesion formation. And these are the AGL guidelines 2017 says primary prevention is application of adhesion barriers significantly reduced. And secondary prevention is use of IUD without copper, semi-solid barriers like hyaluronic acid, and simple pediatric Foley's catheter can prevent all these complications. Now, this is a case which has happened to me. She came to us as a case of secondary infertility. She had Billings stitch and IUD in the past. Now she came to us after 2 years with secondary amenorrhea. We tried doing a hysteroscopic adhesiolysis. I could do a 2 centimeter part. Then I referred this patient to Mumbai for a hysteroscopy workshop. There somebody did a good job. Everybody clapped for that surgery. But this patient lost follow-up. She did not come to me also be in my area. She came to me at 24 weeks of gestation with hemoperitoneum. You can see a simple amniotic membrane is keeping the baby inside the uterus. You can see this. And there is a lot of blood. Why I did not do a obstetric hysterectomy is because MRI showed that it is not rupture uterus. Because you can see these thick membranes which are keeping the baby inside the uterine cavity and baby is not into the peritoneal cavity. I'm trying to see and localize. That's the reason I thought first there is some hemoperitoneum. So we put a laparoscope and then we realized there is a fundal rupture. And she was bleeding inside, but because of the amniotic sac, the baby was inside. That's why it was not giving as a uterus rupture. So in such cases, it is always better to undercorrect while you are doing hysteroscopic adhesiolysis than doing a overcorrection. So, Dr. Prema or Dr. Lungan, you can take this. How much is the myometrial depth you keep at the end of the hysteroscopic adhesiolysis? Or is just you make it and arcuate and leave it?
When we do the myomectomy, hysteroscopic myomectomy, we should exact depth, we don't know, but when we do dissection, we need to cut, when we start seeing the myometrium with vascularity, then
that is the ring vessels, right? But in case of adhesiolysis, where there is an assurement, we are trying to create an imaginary triangular cavity. So in these cases, it's always better to use an ultrasound in the OT. Minimum 1.5 centimeter myometrium has to be kept. Otherwise, you can get such dreaded complications which are life-threatening for the patient. In this case, we had to do obstetric hysterectomy. Baby weight was 600. Baby was in NICU for 12 days, but we couldn't survive the baby. So your newer modalities like hysteroscopic morcellator have better advantages in such cases like this case where there are multiple polyps and there are no injuries, 3-4 injuries, and you can eat out this tissue without any endometrial damage. So it is always better to adopt your newer technologies like morcellator. Removing bony spicule is simpler, and procedure has advantage that is safe, effective, efficient, clear vision is there. And morcellation has advantage in infertility because no energy source is used, no damage to endometrium, intrauterine adhesion is almost nil. You can go ahead with a IUI or IVF in the next cycle itself. It is going to give advantage of visual DNC, removal of bony spicule, RPOC removal. And the take-home message for at the end of this panel is diagnostic and operative hysteroscopy are relatively safe. Complication rate is 2%. Pre-op cervical priming with misoprostol is going to help you for dilatation. Modified lithotripsy position with padded Allen stirrups must and prevents neural injuries. Always insert hysteroscope under direct vision, keeping the dark circle in the center of the field and slowly advance until the cavity is reached. Simple perforation require observation, while complex perforation cause with thermal energy require bowel exploration. Balloon tamponade uterine packing with vasopressin soap gauze is effective for controlling severe bleeding. Automated fluid measurement system provides constant surveillance on fluid deficit and pressure. Fluid deficit balance must be recorded every 10 minutes and at the end of each bag. That is very important. Semi-solid barriers like hyaluronic acid, which is till date not available in India, is going to be helpful. Following aerosolysis, hormone treatment using high doses of estrogen with or without progesterone may reduce the recurrence of intrauterine adhesions. I'd like to thank all my panelists who are such a wonderful people and they were so actively managed. Thank you, Dr. Gopal sir, Dr. Lungan, Dr. Ruby ma'am, Dr. Nirza ma'am, Dr. Yashodan Deka, Dr. Himalina Gautam, Dr. Prerna Keshan, and Dr. Pratibha Agrawal Pasari ma'am for active interaction during this panel. I'm really thankful to all of you that you answered in such a nice way that we could finish our panel within 1 hour. Otherwise, it takes minimum 1.5 hours to finish such big panels. I'm really thankful to Dr. Monica Umbardhan, Dr. Shatabdi for assisting me for preparation of this webinar. And thank you, Team Corona, for giving academic support. Over to Dr. Arun, sir.
Yeah, I have a small question to you.
Yes, sir.
While we are promoting office hysteroscopy and we are doing an hysteroscopic myomectomy as an see and treat procedure, does extraction of the myoma is the issue for your day-to-day procedure, or how do you tackle that?
Sir, those myomas which are more than 2 centimeters, I don't do in an office setup. I do in an operation theater setup, firstly. Secondly, any myoma which is of any big size, you can just keep it there. At the end of the procedure, I use Om forceps for removing the myoma. And even if those myoma which are detached from the uterus, even if kept inside, they will fall off within next 7 days to 15 days. So not to worry, just counsel the patient that such myoma bits might fall off in your menses. You should not be worried. And there are certain European studies where they just cut the myoma and
Leave
keep
it
it inside. How much is a bigger myoma? And that will expel in during menses or during 15 days to 1 month period. So you should not be worried about that.
Yeah, that is the most important information, because while doing an see and treat procedure through office hysteroscopy, I think that is much less painful than extracting the tissue following the procedure, because people remember the sad part first. So that painful stimulation of cervical dilatation and extraction of the myoma or whatever it may be, it becomes more painful to the patients, and that is why we should not worry and just take a biopsy of that particular specimen for the histopathological correlation and the study, and we can leave that particular sample inside. And this sort of counseling needs to go ahead before you take up the procedure. I think you have covered everything so excellently and so diligently. I was just going through for 1 hour. I was thinking, really, you have the leadership, also the equipment to control this panel and the whole webinar within the specified time. Thank you so much for sparing this time for our region.
Now over to Dr. Hafizur for expert comments, and then we'll talk to the panelists.
Yeah, thank you so much, Dr. Kalyan Verma, sir. I think it was an excellent panel, and all the panelists were also experienced as well as younger experience. So that's the word. They have done a wonderful job, and being in the comment, as I know you are doing great work, and I wish every best for you in the Foxy. And I'm being one of your fan, and we would always support you. So thank you for this wonderful panel with all of us in the Eastern region. Thank you so much.
Sir. You know, the best part of this panel was Dr. Lungan is the junior most.
Yeah.
And she had such an experience. Then came Dr. Prerna, then seniors like Dr. Pratibha, Dr. Nirza, Dr. Himalina, and our darling Yashodan and Agrawal.
Agra kab aa rahe ho?
Agra, that's the reason I am coming tomorrow morning.
Okay.
This panel, yeah. You are moving to Agra.
Yes, I'm on my way.
All the best for OT. We have good
Thank
case.
Thank you.
So thank you, Dr. Agrawal, ma'am. Over to Dr. Monica.
Thank you, Arun sir. Thank you, Sujata ma'am, and thank you, Gokul sir, for gracing the inauguration. Anita ma'am for an excellent deliberation, and I would just, also like to thank Dr. Pranay sir and Alka ma'am for chairing the session. Lastly, Dr. Hafizul sir for being an expert for the panel. Our panelists, Dr. Prerna, Dr. Pratibha, Dr. Hindina ma'am, Dr. Lungan ma'am, Dr. Nirza Sakya, and everyone who is present around. Thank you so much, Dr. Gopal also, for being so supportive and taking part in this panel discussion on difficulties on hysteroscopy. We would also like to thank Vashish from Corona Remedies and Shivani for her technical support, Dr. Shatabdi Day to coordinate with each one of you and to send the links and the flyers to everybody. I'm sorry I'm not putting on my video often, but I'm still in the recovery room. And thank you, Kalyan sir, for the opportunity to coordinate this webinar, sir. Thank you. Wishing you all the very best for all your future endeavors.
Thank you.
In Foxy, and we are all looking forward to work with you, sir.
Yes, thank you. And all the best to Dr. Prerna ma'am, who is going for a YTP committee.
Yes.
Thank you so much, everyone. Thank you so much.
Thank you so much, everyone. Kalyan sir and everyone for
Thank you
giving.
so much, everyone.
Can you just stop the
Thank you,
recording?
ma'am. Thank you so much.
Stop
Thank you
unofficially.
everyone. Thank you so much.
Thank you, Monica ma'am. Thank you.
Thank you, everyone. It's an excellent webinar. Thank you.